uh, bone marrow transplant has been around the longest, and it's been used in people with sickle cell disease. I can remember when I was a resident, or it was back in the 80s, and it was not, they hadn't really perfected uh, uh, bone marrow transplant at that point. But now, these many years later, bone marrow transplant is uh, relatively safe and very effective. So, of course, it's very involved where you have to, first of all, for a bone marrow transplant, you have to have a donor. So you have to have preferentially a sibling with the same parent, your same parents, who is an HLA match. An HLA is an immune uh, group of uh, genes. And if you match for HLA and you have a sibling, a full sibling, that is the best donor. Most people don't have that. So then you can get a matched sibling, a matched donor who is not related to you. And they're in research, recently they do half match. So instead of getting 6 out of 6 of these HLA that are matched, or 10 out of 10, it could be 3 out of 6 or 5 out of 10, depending on how they do the matching. And those transplants generally have the same risks and benefits as a full match. Um, the problems with uh, transplant primarily is what's called graft versus host disease. That means that before you get a transplant, you get chemotherapy to make, they call it making space in your bone marrow for the new bone marrow that is going to be infused from your donor. And so you get a chemotherapy in order for those cells to come in and engraft, start growing in your bone marrow. But if the donor can actually, the immune system that's reconstituted from the donor can start rejecting you. So that's called graft versus host disease. There are some new techniques that really decrease the incidence of that, but it's still a risk. And it can be acute and easily treated, or it can be chronic and be a pretty big problem. Um, and the closer the match is, that's why a HLA match sibling is the best. The closer the match is to you, the less likely that that's going to happen. So gene therapy is, so the graft versus host disease, while you're immune suppressed, which can be a month or so, 6 weeks, you're susceptible to infections, overwhelming infections, because you don't have an immune system that's very functional. So you have to be in a special room and precautions so that you don't get an infection. But those infections right afterwards, or even later, that you could still get an infection later and have a problem. Um, those are the big things. And for what we always say here is, if you're thinking about doing that, or you know that there's some possibility that you need to talk to the person who's doing the transplant, the actual transplant doctor, to find out, you know, what are the side effects, because it's more than what I just told you. There's a lot of issues about whatever kind of conditioning they use, where the cells come from. It's a big decision to make, because it's life-changing, but it's also less so, but it's also life-threatening. So you can have side effects from a transplant. Gene therapy, unlike a transplant, the cells that are going to be engrafted come from you. So they use something called apheresis to collect cells to collect blood, and they take out just the stem cells, the progenitor cells that are going to go into your bone marrow and and start making new blood cells. And there's two types of gene therapy that are FDA approved in the United States. One inserts a new hemoglobin gene that has been engineered to be resistant to sickling and actually interferes with sickling. It's not hemoglobin A like I have it, but it functions exactly the same. But it was engineered especially for gene therapy so that it would inhibit any sickling. Um, and then the other one it increases it takes your bone marrow or your progenitor cells, and it increases the fetal hemoglobin. So when you reintroduce those cells, your fetal hemoglobin goes to a level that's so high that you don't have any you don't really have sickle cell symptoms anymore. Um, so both of them are very successful, and you don't have to worry about graft versus host disease. In the first one, there's been, I'm thinking, two people who have gotten um, AML, which is a kind of a blood cancer. It's not really from the gene therapy, it's from the conditioning. It's the chemotherapy they give you in order to get you ready for the gene therapy. Um, and that's really a rare effect, but it's still a possibility. And but you don't have to worry about graft versus host disease because they're your cells. And so when successful, both of these therapies are well, the bone marrow is long lasting. People who have had a bone marrow 20 years prior are still fine. And the gene therapy is new. So we well, people who do the gene therapy expect that it's going to have that it's permanent, that it's not going to change. That those cells are just going to keep proliferating in your body, and you're not going to have sickle cell anymore. But because, as Cassandra said, because it's so new, we don't really know how long, 10 or 15 years from now, we'll be able to say, it looks like it's definitely durable and it'll last a lifetime, which is personally, I would expect that would be the case. But until it happens, you don't know. In medicine, there's side effects to everything, and there's a lot of unknowns, even though some people think they know, things happen in medicine. So nobody really knows how long uh, gene therapy will last. But the expectation, and if you were, it just seems like it would last like a bone marrow transplant for a lifetime. So those are the two
So,
types of transformative therapy that you can get. If you're in a developed country like the United States or in the UK or the European Union somewhere, they're very expensive.
so
They
yeah,
take the,
that was one of the follow-up questions. How much does it cost? And if it's not available where you're located, then
yeah, it
that's
costs,
not
it's hard to put a price tag on, but it's about $2 million per
it's
treatment.
$2 million. However, um, all of the people that have gotten it so far, both therapies have not paid out of pocket.
Right,
So
right.
so insurance is covering it. They're looking at different models on how you cover it. This is here in the United States, right? And like I said before, it is not available widely across the globe as of right now. So if you did want to have access to a gene therapy, you would have to come here, or or I don't know what the logistics are, right? But it, the person who's asking how much does it cost, it depends on where you are and how it's covered and if it's available. If it's not available where you are, then you don't, yeah, you can't really ask how much it costs. If you're here in the US, so far, nobody has had to pay out of pocket for any of these new gene therapies. Um, in terms of bone marrow transplant, um, because it's still being studied, it is still within, I guess, clinical trials. And so typically, costs are covered within clinical trials. If you're participating within a clinical trial, it's usually not any cost to you outside of like, the energy you're putting into the process, right? That's always a cost or, some of the sacrifices you have to make for that. But, not monetary, but, all of those other costs. And so that's to kind of cover what how much it'll cost as of right now. I don't think a lot of people know that people are actually getting these therapies at no cost to them. The media did kind of a hit job on this whole thing, in my opinion, because they led with that. They led with this is going to cost $2 million, and so most of the community, half the community already wrote that off. Like, oh, this is not something that's attainable to me. And that's why you have to, headlines are not great for these types of things. And there's nuance and you have to do your own kind of investigation and really verify this because and speaking to a lot of the companies that produce these therapies, not one person has had to pay out of pocket. So I want to make sure that's clear here in the US. I don't know what the situation is in the UK. I believe one or both of them are available and approved within the UK as well. But the UK has a NHS, right? And they have that system, which is different. So it just depends on where you are, where you live, and whether it's available to you.
And some insurance companies may actually pay for this because it's been shown that these therapies are cost effective. In other words, if you get one of these transformative therapies uh, early on, then the cost to take care of you is no different than taking care of me, more or less. And so for the insurance companies, they're looking at the fact that, if we upfront this, then we're gonna
Yes.
because it's all about in the United States, it's all about money. And so they realize this is cost effective.
Sickle
Um,
cell costs more than being cured or
yeah.
being having that therapy.
The other thing with gene therapy, it requires a lot of infrastructure. So when your cells are collected, they go to a lab that ha, it has to be a special lab that can do the actual gene therapy of that I explained. So it takes more than just a hospital that does a transplant and has availability for all the infrastructure. And for gene therapy, the infrastructure's level are too higher. So wherever you are, they have to have the ability to do the transformation in a laboratory and send it to the lab, have it come back to the hospital. So there's more infrastructure involved in gene therapy.
There's a couple follow-up questions here. Do you have a logistic on how many patients have been successful on gene therapy? I don't know. I think I've asked for that number as well. I don't know that I have it,
No,
but I think it's something we can follow up on, because that's a good question. How many people have undergone this and then isn't there an age limit? There is age limits based off of what therapy you're looking at. So here in the US, there's Casgevy and then there's Lyfgenia. Um, and both are, both transform sickle cell in different ways. And so each one of them I has their age limits and you just have to look into what that age limit is for each one of them.
I think in the studies it was 12 years old, but um, now that they're not studies anymore, they may have changed that age limit.
Okay. Is it true the older you get, the worse the pain gets?
Uh, I would say as you get older, there's more, like Cassandra says all the time, even when you're sitting around and you feel fine, there's sickling. So as you get older, there is, there can be more damage, and the pain doesn't necessarily, I mean, I think I'm just trying, it doesn't necessarily get worse. I think the pain seems, you know, Cassandra can talk to this, but I think the pain gets worse sort of in your 20s and 30s, maybe. And as you get older, the people that I know that are much older, the pain is maybe it just doesn't seem as bad. But then the other thing is, depending on whether you have therapy. So, a friend of ours who's now in her seventies, she's my age, she's in her 70s. She was on transfusions, was sick all the time, and then she started hydroxyurea really late in her life. Like I think she was in her late 60s or maybe even yeah, probably her late 60s. And she stopped transfusions and she doesn't have any pain. So it depends on what your therapy is and how you and where you live and a lot of other things that are um, that you can't control so much. But I don't think it's scary. It can get worse as you get older, but I don't think that's for everybody. That doesn't happen to everybody.
Yeah, I wouldn't say worse. What I would say is you do have more chronic pain because the sickle cell is, constant within your life. Things are getting damaged within your body, right? And a lot of people don't know that sickle cell is a progressive disorder, right? And so, um, with that comes chronic pain. And so, in terms of intensity, you know, I don't think there's an age limit on that, right? I think the pain crisis can be intense as a kid and they can be intense as an adult, and however um, far up you go. But what is typically seen, and Dr. Q, correct me if I'm wrong, what's typically seen as chronic pain is more prevalent within adults with sickle cell. And the chronic pain is that pain that you have every day. You know you're gonna have that pain tomorrow and the day after that and the day after that. And that's just because, there's wear and tear on your organs and there's wear and tear on your bones and tissues and all of that, which causes that pain.
Also, you're depending on your what your therapy has been to for pain and everything. Chronic pain can actually be changes in your central nervous system that actually you have to think about it. You're having these pain episodes throughout your whole life. You have this kind of background pain. And so you can have chronic pain that's due to actual changes in your central nervous system. And that's why we've talked about this before, that even people who have chronic pain, who have a bone marrow transplant, don't have sickle cell anymore, still have pain, sometimes for months and months and months after the transplant. So pain is really a difficult issue on many levels, but it is something that people with sickle cell deal with for a lifetime, really.
I see here. Hi, Dr. Q. It's Ashley Holly.
Ashley, how are you doing?
Mhm. All
Oh
right.
man.
So, pain doesn't necessarily get worse as you get older, but it can you can have additional sort of pain called chronic pain. Somebody says, what about erythrocytophoresis?
Oh, yeah. Okay, so I used to do, I
What,
start
how do you pronounce that, first of all? I don't think I pronounced that correctly.
arrhythmia. No, you
Yeah, I
pronounced it
did.
right.
Oh, okay,
Yeah,
nice,
yeah.
nice.
So I started the program at Children's Hospital in Oakland with apheresis. Actually, not alone. I had nurses who were really smart who helped me do it. I also had the people who made the machines came in and helped me do it. It was not nothing. There's few things in it in any medicine or anywhere where you do things totally by yourself. Anyway, so erythrocyte apheresis or erythrophoresis, or sometimes red blood cell exchange is
Oh, is
what,
that what that is? Is
yeah.
that okay? That was a fancy way to say red cell exchange then.
That's what that's what most people
You guys are
call
so
it.
sophisticated out there.
Anyway, so what so the issues with the good thing about red cell exchange is that it removes the same amount of your red blood cells as it takes out. So when, relatively speaking, it's not exactly the same, but it increases your hemoglobin without adding too much more blood. Depends on what your hemoglobin is when you come into the therapy, but it doesn't add a lot of red cell. It doesn't add a lot of new hemoglobin or red cells to your body, so that the iron the the iron problem is less because you're not getting as many red cells and your body's exposed to less iron. So that's a good thing. The other good thing is that it's really fast. It doesn't take very long, maybe an hour and a half or so to do a red cell exchange. And if you're on chronic red cell exchanges, you may not develop iron overload for a long time or at all, and it depends on the physician who's ordering the red cell exchange and decides what level of hemoglobin they would like to have you leave with. And it also depends on whether this is an acute exchange because you've got acute chest syndrome or some other life-threatening problem, and they need to get rid of all your red cells, your sickle cells, and replace them with donor cells, which can be done really rapidly and can really change the outcome of severe acute chest syndrome or other complication of sickle cell disease. It does require that you have someone, a doctor that's familiar with it, and nurses who know how to do it, and machines to do the therapy, and a blood bank who can provide the blood. So in a regular transfusion, you might get you might be exposed to 1 or 2 units of red cells, or maybe three during a transfusion, but during an exchange, you could be exposed to 6 units or 10 units. It depends on the parameters that they're using to do the exchange. So you have to have a blood bank that can provide eight uh, um, matched red blood cells sort of in a volume. And it's easier to do that if you're on chronic red blood cell exchanges, but for an acute exchange, it requires you to have a blood bank that can do the typing on it has an inventory available to them in a blood bank somewhere where they can pick out the units that are going to match you. It turns out, and at least when I was doing it, there was some evidence that the antibodies you make, or the problems you have with getting those units, doesn't seem to be the same as it would be we called alloimmunization. Wouldn't is not the same as it would be if you were getting simple transfusions. It seems like even though you're being exposed to a lot of units of blood, you don't tend to make antibodies against all those units as you might if you were getting them in a simple transfusion. I don't know if that's really doesn't, it's kind of counterintuitive actually. So I don't know if the research that was done years ago has turned out to be true. It could be, but I haven't seen any recent literature about that.
Okay. My child is 9 and having chest pains. Doctors can't find anything wrong.
Well, that's because your child has sickle cell disease and maybe having bone infarcts. It's in little kids, I'm a pediatrician, so in little kids, it's kind of hard sometimes to figure out exactly what's going on because they're not articulate and they can't really pinpoint things in their body. But, your child could be having pain episodes in, bone infarcts in their ribs or something else going on. If it's chronic and it doesn't go away, then it really needs to be investigated to make sure that everything else is okay, because people with sickle cell disease can have other things happen to them that has nothing to do with sickle cell disease. You can't blame every symptom that you have on sickle cell disease because it could be something else. Um, but I think with kids, it's really hard for them to localize the pain. But chest pain is something to be focused on because acute chest syndrome is life-threatening, and you can't, even though maybe your child complains about it a lot, you can't really blow it off and say, oh, he's just complaining again. You have to investigate it, make sure he doesn't have a fever, he needs to be worked up. And if it's really chronic all the time, then it really needs there's a reason for that. So it needs to be investigated. And maybe if he's really young, maybe he gets attention from doing that, but you can't assume that.
Okay. Um, is there anything that she should be doing to figure out or to get to the
Uh,
bottom of that pain?
I think what she needs to do for her primary care physician needs to every time, unless I don't know how frequently it is, but you have to really investigate every time if someone's complaining about a symptom like chest pain, you have to make sure that that there isn't a problem. It's like you can be complaining about chest pain and you can't find an easy reason, and but you should really be looking for a reason, and make sure that what what the person is complaining about is not a big problem. And it depends on how far you want to go with that in terms of, do you need x-rays? Do you need a CT scan? Are you looking for a pulmonary embolism, which would be like a very acute thing? It wouldn't be reoccurring. Is there, is he have you could is he having bone infarcts in his ribs or somewhere? And then you also have to have like a social worker or somebody, who can talk to them and figure out, what's really going on here. If you do this, all the big workup and you can't find anything, then you have to kind of figure out what else is going on. But you can't ever, even if someone says, oh, your kid is just complaining because they get a lot of attention when they do that. You can't blow it off because, you can cry wolf, but then when something happens, with chest pain, it can be life-threatening. So you can never not pay attention to it.
Okay. Um, how do you feel about the new medication? I'm guessing this is Adakveo. It says Adavico, but I'm guessing it's Adakveo.
Which,
That's the question. How do you feel about the
yeah,
new
what's the
medication?
Adoxio? Which one is that?
That's the crizolizumab.
Oh, I can't remember. I can remember the generic names, but sometimes the other names just kind of
Yeah.
crizolizumab.
So it's not quite brand new. I mean, I
Yeah,
guess
it's
new
not.
is in the context, but
Yeah,
it was approved in 2019. So
yeah,
it's been some time now that it's been out there.
yeah. It's been around for a while, and it's not approved in the EU because it's not approved for reimbursement because they feel like the studies haven't really shown that it's as effective as I don't know what their criteria is off the top of my head, but has been as effective as they'd like it to be. And there was just a study that was a phase 3 study, and it took place in different countries in Africa, and there were a lot of people involved, a lot of subjects involved in the study, and it turned out that it didn't quite meet the criteria that they set for success. And so that people don't really know. It was a really complicated study. They're, they they were in third world countries where you couldn't really monitor people like, and there were a lot of people in the study where you couldn't do it. Like if you do it in the United States, you really, or in a developed country, you can really have a better understanding of what people are going through and monitor their therapy better. But in this situation, which was a very big study, they didn't really have that ability. My impression is that they didn't really have that ability, so the study did not meet its the criteria, which was that uh, there would be no or very few side effects from the medication. So it's kind of it wasn't definitive, I'll put it that way. And
So
it
is this
and
still available to
yeah,
prescribe
yeah,
to patients here in the US?
yeah, in the United States it's FDA approved, and you can get it again. Don't take my word for it. What you need to do is go to your primary care doctor and see what they think about it. I mean, their experience with it may be that it really was beneficial for the people they gave it to, or they might say, well, it wasn't it wasn't as great as I thought it was going to be. You just have to talk to your doctor, get their experience in your situation as to what would be the best therapy for you. Um,
Yeah, and that would be your sickle cell specialist, not
right,
your normal
right.
general doctor. Your sickle cell
Yeah,
specialist would
right. The
know more
person who's
about
going to be
that.
giving you the medication.
Mhm.
Because it is an IV medication, you have to go in and get it's a, go into a day hospital for it, etc.
What is the doctor's name? This is a doctor introducing Dr. Keith Carrillo. I'll type it out here.
Who's
Dr.
a
Keith.
retired pediatrician who took care of children and young adults, not older adults, but children and young adults with sickle cell
And I
disease.
happen to be one of those
Yeah,
children.
and right. And some of I retired before Cassandra got to be too old, but some of my patients were in their 20s. My oldest patient was, I think, 30 something. They just didn't want a different doctor. So
What do you
it's
say to patients that, or people that say the doctor is going to recommend it so he or she can get paid?
recommend what? Crizolizumab?
I'm guessing.
Uh, you know, th- I personally, there are people like that, but I think 90% or more of doctors don't do things to make money. I don't think, there are people who are kind of like that, but doctors don't generally do that. And if you thought that was true, then what you're saying is that I do not trust my primary sickle cell doctor. That's what you're telling me. And so my response to that would be, well, maybe you should find a different doctor. Because you really have
Yeah,
to,
if there's that
there
distrust,
has to
right?
be some kind of understanding between the doctor and the patient. You have to trust the doctor that you're putting your life in their hands, right? So you have to really trust your doctor. You can't think, oh, he's just admitting me for all this stuff because he gets a kickback from the hospital or whatever you think. If that's what you think,
It's
then
not
you
a
got to
fit.
reassess
Yeah.
what's my relationship with this person. Doctors are people. They're not, they don't walk on water or fly around. They're just regular people. So, so you have to really, assess the person who's taking care of you as a person. Is this the person that I want to be the person who's taking care of me and is trying to save my life or make my life much better? And if you can't, if you kind of say, I'm not sure about that, or no, then you've got to go shopping, find somebody else.
Yeah.
And they may be a good doctor. It's not saying they're not good. It's just that for the dynamics
Yeah, it's
between
not a
you and
fit for
that
you.
person just don't click.
Yeah. Um, yeah, so it's the drug, the therapy that we've been talking about is called Adakveo. And then what's the name of it? The scientific name is called crizolizumab. So a lot of therapies have that scientific name, which is what Dr. Q knows it as. It's crizanlizumab. And then the brand name is Adakveo, if there's any confusion there. Um, there, there are really bad doctors. Trust your intuition. That's my mom. That's my mom, by the way, guys.
That,
Yes, but
the other
yeah,
thing is, I don't think, well, maybe I think there's more disagreeable people who are doctors. It doesn't mean that they're bad doctors. It means that you just
it's not
don't
a fit.
click. And there are some really bad doctors, that's for sure. But I don't think there's like a lot. But there may be a lot of people that you just don't get along with. It'd be like if you go down to the bus stop and you look, there's 10 people there, how many of those people are going to get along with? Maybe none of them. And it's different with sickle cell disease. So I have a doctor. I see this person once a year, maybe. I'm not a very good patient. I don't go in very much.
Doctors aren't
But
usually good patients.
yeah, we are.
That's
Anyway,
what I
when
hear
if you have a chronic illness like sickle cell disease, that you're interacting with that person
a
a
lot.
lot
Yeah,
more than I'm interacting with my doctor.
right.
And even if I didn't really like his personality, it wouldn't make any difference because I don't have to talk to him but once a year. So it's like, oh, I can handle that guy for an hour a year. But that if you have sickle cell, you're having that person an hour a week, an hour a month, or and when you and I'm pretty healthy, but that's the person you've got to trust to get you into the hospital and get you through really bad events. And so you really have to have a relationship where you think that person is a good doctor and that you can get along with him and tell him anything. And he's not going to fall over off his chair or something. That's your job as a doctor, is to just take good care of people and don't be judgmental about anything. You're there to take care of that person, you're not judging them for any reason. So,
So I see somebody says here, their doctor tried to put them on Adakveo and Oxbryta. They said no because they knew of the fatalities. I just want to there for Adakveo, there weren't any fatalities involved with that. For Oxbryta, just to break this down a little bit further, and Dr. Q, please feel free to jump in.
hmm
Um, when they do clinical trials, there are deaths within those clinical trials that they have to report. Not all deaths are because of that therapy. They could, for example, if somebody's in a clinical trial for Oxbryta and they get in a car accident, they still have to report that as a death. And so the new data that's come out shows that Oxbryta itself did not cause any fatalities. Um, they are we those fatalities were seen in sub-Saharan Africa, and don't quote me on this, but I think some of them were due to malaria, were due to people not being able to get to the hospital on time, but they weren't directly linked to Oxbryta. So I just want to make sure that you all know that neither one of these drugs are tied to fatalities as of right now, right? And um, I don't want you all to think, oh, these drugs cause people to die, because that's not the case. They still have to report deaths. Some people die, sickle cell is brutal, right? And some people die just because they have sickle cell, right? And they could be in a study. All of that has to get reported. And so, for the sake of reporting those things, yes, when the data comes out, it shows that they're deaths, right? But you have to look a little bit deeper and see what the cause of those deaths are. And as of right now, there aren't any causes due to either one of those therapies, Adakveo or Oxbryta.
Right. So, these medications are for people who are really sick. I mean, everybody listening to this, you all have sickle cell disease, and you know that most people have who are in their 20s or whatever, they've had at least one life-threatening event. So, um, that there's that, but then there's also, if you're doing a study in Africa, like Cassandra's saying, people die from all kinds of different things. And if you're in the study and you die from malaria or you die from some other infectious disease that has nothing to do with your sickle cell disease, those are reported. So that you really have to look into it. And in the paper that I read, there were deaths from malaria and other events that didn't really have anything to do with sickle cell disease or for definitely with the medication. So, and one of the problems is in these studies where you do them in a third world country, you can't really be sure that the person is really taking the medication. And if it's something that's given intravenously, they may not be able to get to the clinic. There's just so many um, intricacies in a study. And it's hard to keep. The bigger the study is, the harder it is to keep your finger on things and really know what's happening in the field. If in a third world country, like in the United States, the European Union or something where you've got all this infrastructure, you can you can have a better handle on what's really going on with the subjects in the study. But in big studies in third world countries, it's really difficult to control the study, is what they say. You can't control what's going on with the people in the study. And so in that study, there were deaths from malaria and other reasons that were not had nothing to do with sickle cell or the medication. I don't
Yeah,
know.
you have to
I don't
remember
know.
people die with sickle cell for a multitude of reasons, whether they're
Yeah,
taking, people die on hydroxyurea, people
right.
die on oxybate, people die on a whole bunch of array of people die when they're taking Tylenol, right? And so it doesn't mean there's a direct
Right.
correlation. And
Right.
so I want you all to
Yeah.
remember that it doesn't, if they're seeing like lots of people die, and they all have that in common, then that's a direct correlation. But if you just happen to die while you were taking a medication, that's not necessarily a direct correlation. And so you have to kind of just, I know you said that Hertz passed away. We don't actually know that he passed away from Oxbryta.
Right.
Um, that's just not verified at all. So, um, just when you hear those things, just take it with a grain of salt and really do your digging and make sure that that information is accurate.
And you have to look at it if it's something that's available. I can tell you it's available in other countries, whatever, outside of a study. If somebody died from a medication, it would be news. I mean, I can't think of anyone who was getting a medication the way it was prescribed and being monitored by a doctor who died from the medication. They may have died for some other reason, but I can't off the top of my head think that there was ever any sickle cell medication. Well, historically, they gave some pretty crazy stuff to people with sickle cell, but in this modern age, somebody who died from therapy. That's not that, you know, that's excluding like bone marrow and and really high risk therapies like that, where people have had some issues with it, but not much recently. Things today are, in my lifetime, medicine has changed dramatically. I mean, and now people are, I think most therapies in developed countries go through a huge process to make sure they're safe before they go to and in this country now we have a administration where you hear all this crazy stuff that, you know, that may not, you can't, it's a sad, but here in the United States, you can't trust what people in the government tell you about medications and stuff and vaccines and all that. So right now we're in a really tough time for science and medicine.
Yeah. Okay, I have time maybe for two more questions. We have 9 more minutes, guys. And you know what? I think this is going to be our last session for the year, and then we'll be
Yeah.
back in
Oh my God.
2026.
Yeah.
So, you guys, if there's any burning questions,
Yeah.
please feel free to put it in the chat, and we will try and get them answered. If not answered,
Right.
then please feel
Well,
free to send in your
we'll answer
question,
them next year.
or we can answer them next year. Um, oh, thank you. That was good information. Thank you. Yeah, it's just yeah, a lot of this is hard, and there's a lot we don't know. There's not a
Yeah.
lot that behind the scenes that we just don't know on. But yeah, it's tough to navigate a lot of this information. It really
Yeah.
does take an expert. You have to be an expert in your own right to really understand all the data. And even me, you know, it's a lifelong learning
It is.
process.
It's like new drugs come out, new therapies, and
And they
it
don't do a
takes
very good job of educating us either. So
right.
it's not your fault at all. It's just,
And I think, you know, even if you're not a if you have your physician isn't really a sickle cell physician, it's hard to keep up with the there's so many articles that come out, there's so many changes, it's hard to keep up. Um, I mean, if you there's something called PubMed, and if you put in sickle cell disease, you get like thousands and thousands of articles. So it's hard to keep up.
all right. I'm gonna I don't see any questions coming in, but I had a couple follow-up questions around gene therapy. Um, let's see, actually, uh, uh, you guys, I don't know what to do. Okay, here we go. When will my baby's numbers be stable, meaning knowing how much fetal hemoglobin she
Uh,
will maintain with sickle beta plus thalassemia? So I guess your
oh,
baby
sickle
is,
beta plus thalassemia. Okay.
yeah, so I guess your
Okay.
baby is, well, under 2, maybe.
Yeah. Yeah. So I can tell you something that I don't tell too many people about, but here I am telling everybody. So I had a patient once who was taken care of by her grandmother. Grandmother was really worried about her. And, you know, she came, we got, I started taking care of children when they were like babies, like 2 months old or something like that. And so she was really worried about it. And so what I did with for her was every time that child was to have a blood draw for some other reason, I always got a fetal hemoglobin. And what it turned out was this is a study of one, so there's only one person, but it turned out she had pretty high levels of fetal hemoglobin since she was about 2 years old and no symptoms before two. So the fetal hemoglobin hangs out for quite a while in children. Um, but it's variable. You just don't know. So that's and with S beta plus though, like sickle cell anemia, SS is the same for everybody, but the symptoms are different for everybody. But S beta plus thou that plus is how much hemoglobin A, normal hemoglobin you have. So your symptoms depend on what the level of hemoglobin A is. So people with S beta plus cell would even have a more unpredictable course. But generally speaking, people with S beta plus thal, um, there are exceptions to everything, and I know a couple from my practice, but generally people with S beta plus thal do very well, with few exceptions. And one of the problems with S beta plus thal and some of these others is that the kids are so well, they never come back to the sickle cell clinic. So we can't, sometimes we just don't know what the course of the particular disease is because they aren't sick enough. Like there's one called, there's hemoglobin E is really common in California, and SE, I wanted to do a study on SE, but the kids weren't that sick, so they didn't come back to the clinic enough to do a study. So S beta plus style depends on how much A you have, and the outcome depends on that and some other things. I have seen most people do fairly well with S beta plus thal, but not everyone.
But
I have
when do you find out that what their stable
probably when
hemoglobin
they're
is?
over two, they'd have to be over two. That, maybe school age, 5, something like that. But
Okay.
um I would say if I was doing that, I'd wait until after 2, just check it. And you do get blood draws, and you could talk to your PMD or your provider and just say, I'm worried. Can you figure out what, do a hemoglobin test or something like that.
Yeah.
But again, the labs don't necessarily correlate with the disease. So the labs may look great, but the person may not be looking as good as their labs look. So they're not really a predictor of anything.
Yeah. I see here. I get that, but Pfizer pulled Oxbryta for a reason. Yeah, you are right about that. And it really is a longer conversation on why they did that. And they didn't do everything correct, right? Or, there are things that could have been done better, especially with that being pulled. Um, but they did take a look at the data, and the data is available, and that data um, showed that it could cause more pain. Socks, right? It could cause more pain, but they also looked into the data to see if there was higher death rates associated with taking Oxbryta, and they found that there were not. Looking at, and they looked at 4 different types of studies to see that. There's one that was in Africa, one here. So they pulled it out of precaution because, they wanted to make sure that if there a correlation between the two, they wanted to make sure they're not hurting additional people. But then they went back to look at that data. But I don't necessarily like talking about these, and I would suggest you have the conversation with Pfizer. But this is my understanding of this, right? But I think people have a right to feel, you know, how they feel about things. Just make sure, that information is correct information at the end of the day. That's all. Um,
And there wasn't much that came out that when it was pulled, there wasn't much that was divulged as to exactly why it was pulled. It was just pulled.
It's a tough conversation because
Yeah,
yeah, and I don't necessarily feel like I'm necessarily the right person to
yeah.
discuss this. It should be maybe with a provider or with Pfizer, and there are Pfizer representatives who can have the conversation with you to kind of just sit down and you can ask them anything, right? And some of their answers may not satisfy you. Like I said, I don't didn't think they were perfect and um, the way they handle things. But, facts are facts are facts at the end of the day. So,
And I think,
um,
pharmaceutical companies are very sensitive and if they, so when they took over, somebody just decided that there was some risk involved or something. I don't know. It's really fuzzy. Um,
yeah, yeah.
but like Cassandra said, you'd have to talk to somebody who was knowledgeable and who was in that somebody in the pharmaceutical company who knew why they pulled it. Because I'm not sure that any, general people even, and maybe
I don't, and yeah, I don't think that,
some
yeah,
physicians
yeah.
who worked for Pfizer might know, or worked for Global Blood Therapeutics, but not you and me and stuff like that. Nobody really knows for sure. It was never published why exactly they pulled it.
All right. That's us. That's
This is,
2025.
yeah, 2025 is all over for us. We're looking forward to 2026. And I'll
Yeah,
give,
and thank you for asking the tough
yeah,
questions too. Like I
yeah,
really
yeah,
appreciate you,
yeah,
putting all of that there. Because those are real concerns within the
yeah,
community,
yeah,
right? And I do think the conversation should be had. And ugh, gosh, I enjoyed all of your questions this
yeah. For
year.
the
You
year,
guys
yeah,
always show
yeah.
me how knowledgeable and sophisticated and how I need to get
Mhm.
up on your
Yeah,
level with
yeah,
all of this. So thank you so much for um, being part of this
yeah,
and asking your questions and um having these conversations. I think they're important. So
yeah, they
thank
really
you so
are.
much.
And your comments, some people's comments that come up that everybody can see are very helpful.
Yeah.
You know, they're
Yes.
really good. Yeah.
All right.
So
Well,
we'll see you next year. And I have to
yes.
give my little disclaimer, which
Yes,
is
you do.
this this program is just for information only. We aren't trying to tell you to take or not to take a medication or therapy or whatever. And we're also, me personally, I'm also fallible. So I'm answering these questions kind of off the top of my head. And so sometimes what you hear from me may not be exactly correct, or it could be totally wrong. So what you have to do is go to your primary care physician and ask and try to get the information how these things apply to you, because sickle cell disease is very diverse and only your physician knows your past medical history, what's happened to you, what medications you're on, and all that kind of stuff, which we don't. So you really, if you want really good advice instead of just information, you should go to your primary care sickle cell doctor to get that information, or somewhere else that is more definitive than we are, because we're just doing this. We don't have a book open next to us to figure out, is this exactly perfectly correct? But I really appreciate all your questions. I really appreciate they all came in today to ask your questions. This is really fun for me to do.
Yeah, thank you. Thank you all so much. We
Yeah,
appreciate you so very much.
yeah,
And we will see you next year.
yeah.
Enjoy the holidays.
Yes,
Make sure
happy
you rest,
holidays.
drink your water. Don't
Yeah,
get sick. Don't wind up in the hospital. Don't
right.
stress over the holidays. Don't stress.
Don't celebrate with alcohol on New Year's. So that's my advice. And drink a lot of
Okay.
water.
Oh,
Yeah.
okay.
Cassandra.
Yeah. You guys have a wonderful holiday season and Happy New Year's, and we'll see you
Okay.
all in the next year.
Okay. Bye bye, everybody.